In this disease, there is migration of thrombus into the pulmonary circulation. Migration of thrombus into the pulmonary circulation. What is this disease? It is pulmonary thromboembolism. Write down the definition of pulmonary thromboembolism. It is migration of thrombus. It is migration of thrombus into pulmonary circulation. Migration of thrombus into pulmonary circulation. This is called as pulmonary thromboembolism. What are the predisposing factors? We have genetic factors, acquired factors. Genetic factors such as protein CS deficiency, factor 5 lead-in mutation, protein CS deficiency, factor 5 lead-in mutation, then hyperhomocystinemia. Hyperhomocystinemia. Let it be any of this cause. Let it be any of this cause. The ultimate result is hypercoagulability. The tendency of the blood to form thrombus increases. Protein CS deficiency, factor 5 lead-in mutation, hyperhomocystinemia. Coming to acquired causes, recent surgery or trauma, recent surgery or trauma, prolonged immobilization, prolonged immobilization, malignancy, pregnancy, estrogen containing pills. How are estrogen containing pills predisposing for pulmonary thromboembolism? Because estrogen containing pills will cause a side effect called as deep vein thrombus formation, and these deep vein thrombi can migrate into circulation. Then malignancy. In malignancy, the tumor cells can produce few substances which can increase the thrombotic tendency of the blood. Then in pregnancy, generally pregnancy is considered as an hypercoagulable state. Presence of varicose veins, and these varicose veins can harbor deep vein thrombus which can migrate into pulmonary circulation. Nephrotic syndrome. Why will nephrotic syndrome be responsible for pulmonary thromboembolism? In nephrotic syndrome, there will be massive proteinuria. Like all other proteins, there will be loss of antithrombin 3. Whenever antithrombin 3 is lost, it can cause hypercoagulability. Loss of antithrombin 3 from the body can result in hypercoagulability. So these are all the important predisposing factors for pulmonary thromboembolism. You know, students, your pulmonary artery is connection between heart and lung. Whenever there is some issue in the pulmonary artery, there can be changes happening in the lung, changes happening in the heart. We are going to discuss the pathophysiology of pulmonary thromboembolism with respect to changes happening in the lung, changes happening in the heart. Coming to the lung, consider this is your lung. Let this be the bronchi, ultimately giving rise to alveoli. And on the surface of your lung, most important blood vessel on the surface of your lung, most important blood vessel will be the pulmonary artery. Now suppose there is a thrombus in the pulmonary artery like this. just before the thrombus, there can be increased pressure within the vessel. Consider this is a freely flowing blood vessel. Now whenever this blood vessel is obstructed, just before the blood vessel, the pressure in the vessel can increase, that can result in rupture. This increased pressure in the vessel can result in rupture of vessel. Whenever blood vessel is ruptured, there can be development of hemoptysis. Then as there is a thrombus in the pulmonary circulation, now there will be no proper gaseous exchange. There will be decreased transfer of oxygen. That will result in hypoxemia. Whenever there is a hypoxemia, that can result in hyperventilation and respiratory discomfort called as shortness of breath. When there is a thrombus, around the thrombus your platelets can aggregate. Around the thrombus platelets can aggregate. These platelets can secrete serotonin, and this serotonin can cause bronchospasm. This serotonin can cause bronchospasm, and because of this bronchospasm, transiently there might be increase in airway resistance. Because of this bronchospasm, transiently there can be increase in airway resistance. Platelets, they are going to release serotonin, platelets around the thrombi, that can result in bronchospasm. That bronchospasm will increase the airway resistance. As time progresses, the blood reaching your lungs will decrease. There will be lung ischemia. Because of the lung ischemia, there will be cellular injury. So when the cells are injured, there will be release of inflammators. There will be release of inflammatory mediators that results in an ongoing inflammation within the lung. Because blood reaching the tissues has become less, tissue injury, release of inflammatory mediators. Now these inflammatory mediators, if they reach the pleural surface, there can be pleuritis. Pleuritis can result in chest pain. And because of pleural inflammation, there can be formation of fluid. This fluid, it is due to inflammation, so it will be exudative pleural effusion. Because of inflammation, there will be fluid formation, and this pleural effusion will generally be an exudative collection. Pleural effusion due to inflammation, it will be generally exudative in nature. If they ask you what will be the classical presentation of pulmonary embolism, patient will have hemoptysis, shortness of breath, there will be chest pain. Hemoptysis, shortness of breath, chest pain. Coming to changes that can happen in the heart. Consider this is your heart. Let this be the heart. Let this be the right atrium, four-chambered heart. Left atrium, right ventricle, left ventricle, and in between the right ventricle and left ventricle, you are having a good interventricular septum like this. So there is a good interventricular septum like this. From the right ventricle, the vessel coming out will be your pulmonary artery. From the left ventricle, the vessel coming out will be aorta. So whenever there is a thrombus, here the problem is thrombus in the pulmonary artery. A thrombus in the pulmonary artery. So what will your right ventricle do? It will initially try to pump against the thrombus. There will be increased right ventricular pressures. There will be increased right ventricular pressures. Your right ventricle will try to pump against this thrombus, and also there will be right ventricular dilatation. Now your right ventricle will not only dilate sidewards, there will be right ventricular dilatation. It will not only dilate sidewards, it will also dilate medially. So whenever your right ventricle is dilating medially, previously what was present in the center? The interventricular septum. Now the interventricular septum will be pushed more into left ventricle. There will be increased movement of interventricular septum. Increased movement of interventricular septum into left ventricle. Because of that, there will be reduction in left ventricular ejection fraction. Whenever there is reduction in left ventricular ejection fraction, there will be reduction in cardiac output. Reduction in cardiac output. That will in turn reduce blood pressure and patient will land in shock. That will in turn reduce blood pressure and patient will land up in shock. Now you can notice there is increased movement of interventricular septum into left ventricle. So once it is moving into left ventricle, the left ventricular ejection fraction, the amount of blood coming into the left ventricle into the aorta will decrease. That will decrease the cardiac output, resulting in decreased blood pressure and ultimately shock. Now my right ventricle is never used to such high pressures. Whenever there are increased pressures in the right ventricle, it will eventually give up, resulting in right ventricular dysfunction. Now if you notice the changes happening in the heart, there can be right ventricular dysfunction, decreased BP, ultimately patient landing up in shock. Now tell me students, what is this entity of right ventricular dysfunction happening due to primary respiratory cause, excluding diseases of left heart called as, see previously we have noticed because of increased back pressure, a left heart disease can cause right ventricular dysfunction. So that is a regular phenomena. But here there is no left heart disease. A primary respiratory cause is causing right ventricular dysfunction. This phenomena is called as cor pulmonale. So write down students, let us discuss about cor pulmonale. Cor pulmonale is right ventricular dysfunction due to primary respiratory cause, excluding diseases of left heart, excluding diseases of left heart. This cor pulmonale, it can be classified into two types. We have acute cor pulmonale, chronic cor pulmonale. Acute cor pulmonale, just now I have discussed. Most common cause will be pulmonary embolism, whereas chronic cor pulmonale, most common cause will be COPD. Most common cause will be COPD. Apart from COPD, interstitial lung diseases, bronchiectasis, obstructive sleep apnea, obstructive sleep apnea, obstructive sleep apnea. Now my question is, how will a respiratory disease ultimately result in right ventricular dysfunction, especially the chronic respiratory phenomena. The reason here is because of a long-standing respiratory disease, there can be hypoxemia. Hypoxemia in the long run can cause persistent pulmonary vasoconstriction. Whenever there is less oxygen, there are hypoxia sensitive potassium channels in the pulmonary circulation. So this is a special feature of your pulmonary circulation. Whenever there is hypoxia, the hypoxia sensitive potassium channels will react, resulting in pulmonary vasoconstriction. So hypoxemia in the long run will cause persistent pulmonary vasoconstriction because of the special feature of the pulmonary circulation called as hypoxia sensitive potassium channels. Because of pulmonary vasoconstriction, there will be pulmonary hypertension, and my right ventricle cannot tolerate such high pressures for long. It will result in right ventricular dysfunction, which is called as cor pulmonale. So this is the mechanism, students. Chronic respiratory diseases such as COPD, ILD, bronchiectasis, obstructive sleep apnea. So they cause a long-standing hypoxemia. Long-standing hypoxemia can cause persistent pulmonary vasoconstriction that results in pulmonary hypertension, right ventricular dysfunction due to respiratory cause. It is cor pulmonale. Now we have understood the predisposing factors of pulmonary embolism and also the clinical manifestations of pulmonary embolism. Now putting these two together, there is a scoring system by which you can know the likelihood of pulmonary embolism. So what will be the chances of a patient to have pulmonary embolism? So this is called as Wells scoring system. So write down Wells scoring system. So the next topic is Wells scoring system. This is the Wells scoring system. Wells scoring system. These are the clinical variables and this will be the score given. If the patient is having signs and symptoms of DVT, the score will be 3 points. Alternative diagnosis less likely than pulmonary embolism, score will be 3 points. Alternative diagnosis less likely than pulmonary embolism means you are having a strong suspicion. You are having a strong suspicion that this is pulmonary embolism. You are having a strong suspicion, that inner gut feeling. Patient's heart rate is more than 100 per minute. Score will be 1.5. Immobilization more than 3 days, surgery within 4 weeks. Score will be 1.5. Prior pulmonary embolism or DVT. Score is 1.5. Patient presenting to you with hemoptysis. Score will be 1. Patient is having some malignancy. Score will be 1. Patient will having some malignancy. Score will be 1. Now let us see how to apply this score. There was a patient with colon cancer. He recently underwent surgery. Now he presented to me with hemoptysis and his heart rate was 110 per minute. Now what will be the score? Now if you notice, patient is having colon cancer, 1. He underwent surgery, 1.5. He is having hemoptysis, 1. And his heart rate is 1.5. Now putting together 2, this is 3. So 2 plus 3, the total score. So what will be the total score? It will be 5. So you have to add all this. 1 plus 1 is 2. 3.5, 5. The total score will be 5. This is how you should use this table. Now any score more than 4, any score more than 4, it is considered as high likelihood of pulmonary embolism. So PE means pulmonary embolism, students. PE means pulmonary embolism. Any score more than 4, this patient is considered as high likelihood of having pulmonary embolism. Any score more than 4. Now how will we investigate the patient further based on this score? There can be two entities, patients with low score and patients with high score. Now if it is a high score patient, I should not waste time because possibility of pulmonary embolism is high. If the patient score is high, more than 4, the next step will be investigation of choice for pulmonary embolism, that is CT pulmonary angiography. I should not delay a CT pulmonary angiography in a patient with high score. Now if it is low score, the chances of pulmonary embolism is less. So what I am going to do is, first I will do a blood test called as D-dimer. First I will do a blood test called as D-dimer, and based on the value, is it a high D-dimer value or is it normal D-dimer value? If it is high D-dimer value, the chances of pulmonary embolism will be there. So here I go for CT pulmonary angiography. So if it is high, I advise CT pulmonary angiography. If it is normal value, I can actually exclude pulmonary embolism. So how it is done, we will discuss in the next slide in investigations. So the point here is, if the patient is having a high score, don't waste time, directly go for CT pulmonary angiography. If patient is having a low score, first do a blood test. What is that blood test? D-dimer. If the D-dimer is high, then only go for CT pulmonary angiography. So this is a rough estimate of how you should approach further. High score, directly advise CT pulmonary angiography. Low score, get a blood test done, D-dimer, and depending on it, if it is high, you can go for CT pulmonary angiography. If it is normal, you can exclude pulmonary thromboembolism. Now coming to the investigations in pulmonary thromboembolism. Investigations. First, let us start with the basic investigations. ECG. In the ECG, most common will be sinus tachycardia. Most common will be sinus tachycardia. Most common will be sinus tachycardia. Along with that, one can notice T-wave inversions. T-wave inversions in leads V1, V2, V3, V4. In leads V1, V2, V3, V4. But if they ask you most specific, the most specific will be the classical S1, Q3, T3 pattern. What is this? I will show you in ECG, you will understand. Next important investigation, a chest X-ray. Chest X-ray, because it is a disease in the pulmonary vasculature, most often chest X-ray tends to be normal. But there are few special findings. These are not common, these are rare, but can be asked as a question. Now what are these special findings? What are these special findings on chest X-ray that can suggest pulmonary embolism? Let us see. Consider this is the lung. Let this be the lung. Comfortable on a diaphragm. Okay. On the surface of your lung, most important blood vessel will be the pulmonary artery. Let this be the main pulmonary artery and various branches. various branches. Same way. So various branches. Now suppose there is a thrombus in the pulmonary artery. For example, let there be a thrombus here. So whenever there is a thrombus, distal to that thrombus, the blood flow will stop because that vessel is obstructed. Distal to that thrombus, the blood flow will stop. So this vasculature will disappear. So distal to the thrombus, you will be not able to see the vasculature. This area of less vasculature, on a chest X-ray, it is focal aligemia because there is no vasculature, less vasculature. This finding is called as focal aligemia. This area of less vasculature has a special name. What is this special name? It is called as Westermarck's sign. It is called as Westermarck's sign. As time progresses, the amount of blood reaching the lung will decrease. There will be lung infarction resulting in a wedge-shaped opacity. There will be lung wedge-shaped opacity at the diaphragm. This wedge-shaped opacity, lung infarction, it is called as Hampton's hump. Whenever there is a thrombus, especially in the right descending pulmonary artery. So generally right descending pulmonary artery is one of the prominent artery that you see on a chest X-ray. So whenever there is a thrombus, especially in the right descending pulmonary artery, you can see just before the thrombus there can be dilatation of the blood vessel. Now this is the freely flowing blood vessel. So it was freely flowing. Now there is an obstruction here. Just before the obstruction, the vessel can dilate. So this can be seen very well when there is an obstruction in the right descending pulmonary artery. In many of the studies, they could identify whenever the obstruction was in right descending pulmonary artery. This finding of dilated right descending pulmonary artery, it is called as Palas sign. In majority of cases of pulmonary thromboembolism, you should go for a lower limb venous ultrasonography. A lower limb venous ultrasonography should be done. What is the advantage? To rule out deep vein thrombus. Then whenever you do echo of heart, when there is a big thrombus, one can notice your right ventricle has given up, right ventricular hypokinesia. This right ventricular hypokinesia, in setting of a thrombus in the pulmonary circulation, it is called as McConnell's sign. This right ventricular hypokinesia, in setting of a thrombus in the pulmonary circulation, it is called as McConnell's sign. Then coming to a special investigation called as D-dimer. This D-dimer is actually a fibrin degradation product. Write down, I'll explain every point in detail. Fibrin degradation product. This tends to be elevated in pulmonary embolism. This will be elevated in pulmonary embolism. This is sensitive but not specific. This is sensitive but not specific. It is also elevated. It is also elevated in multiple conditions such as, it is also elevated in multiple conditions such as sepsis, DVT, cancer, etc. This has good negative predictive value. This has good negative predictive value, but poor positive predictive value, Because of this, it is used only as screening test, not investigation of choice. Let us see what is this test called as D-dimer. In simple words, whenever there is a thrombus in your body will try to break that thrombus. So whenever the thrombus is broken down, there will be some fragments released into circulation. One such fragment is D-dimer. So this D-dimer will be elevated in pulmonary embolism because there is a thrombus, it is getting broken down. It is a sensitive test. But not specific. Why it is not specific? Now suppose there is a thrombus in my upper limb, thrombus in my abdomen, thrombus in my lower limb. In all these conditions also D-dimer will be elevated. Students, remember this very important point. Elevated D-dimer means there is an active thrombosis undergoing in your body. So it might be anywhere in your body. So if D-dimer is elevated, there is presence of thrombus in your body, but it will not specifically say that this thrombus is only localized to the pulmonary circulation. So it is sensitive, but it is not specific. It will not specifically say that this thrombus is only in the pulmonary circulation. So it has a good negative predictive value. Negative predictive value means ability to exclude the diagnosis. Now if D-dimer value is normal, what does it mean? The chances of thrombus breaking down in your body is less. The chances of thrombus existing itself is less. Now it has poor positive predictive value. Positive predictive value means ability to confirm the diagnosis. Now if the D-dimer is elevated, with this single value can you say that there is pulmonary thromboembolism? No. If D-dimer is elevated, it gives you a direction that there is chances of thrombosis in your body, but it will not say it is only in the pulmonary circulation. So if D-dimer is normal, the chances of thrombus existing in your body is less. The chances of pulmonary embolism is less. So you can exclude the diagnosis. So it is good negative predictive value, but very poor positive predictive value. With single value of D-dimer, you cannot say that there is a thrombus only in the pulmonary circulation. That's why it is used only as screening test, not investigation of choice. Then what is considered as investigation of choice? So what do you mean by investigation of choice? It must be easily available, easily done, less complications, good sensitivity and specificity. So such a test is CT pulmonary angiography. In CT pulmonary angiography, what exactly I am doing? I am injecting contrast into the blood vessels. So what is the function of contrast? Wherever there is blood, it will make that area completely white. So the contrast will go into the pulmonary artery. So pulmonary artery will also appear very, very white. In that area of white, if you see anything less white, it is suggestive of a thrombus, because this investigation directly localizes the thrombus in the pulmonary circulation. This is considered as investigation of choice. Then what do you mean by gold standard? What do you mean by gold standard? Gold standard means it might be difficult to do. It might be associated with complications. But if you do it, you are 100% sure about the diagnosis. Gold standard test will be invasive pulmonary arteriography. Gold standard test will be invasive pulmonary arteriography. Now what is this invasive pulmonary arteriography, students? Here it is not just contrast. You are putting a catheter directly into the pulmonary circulation. You know you are in pulmonary circulation, but that catheter is not going beyond. What does it mean? What does it mean? There is some obstruction. You know you are in pulmonary circulation, but it is not going beyond a point. It means there is some obstruction. So that obstruction can be a thrombus. Now this is gold standard, but it is an invasive method associated with complications. That's why we are not routinely doing it. So for all practical purposes, if they ask you investigation of choice, the single best answer should always be CT pulmonary angiography, students. Apart from this, there was a old test called as ventilation perfusion scan. Ventilation perfusion scan. Nowadays it is outdated, not used routinely, very limited use. So because the mission is not available and the sensitivity and specificity is also not good, so the use of this has been limited. Then where you can use this ventilation perfusion scan? Now for CT pulmonary angiography, you should give contrast. If the patient is having contrast intolerance, either contrast hypersensitivity or patient is having some renal failure, renal issue. In renal disease, you should not give contrast. In that condition, you can use ventilation perfusion scan. Next indication is to decrease the risk of radiation to mother. In pregnancy, it can be used. But recently there are low dose CTs. So we are using low dose CTs also in pregnant mother, and it depends upon the area where we are doing. So majority we nowadays have changed to low dose CT, but if it is not available, ventilation perfusion scan can be a option. So this is regarding the investigations. Now next, you have identified it as pulmonary thromboembolism. How will you proceed for treatment? How will you proceed for treatment? Coming to management of pulmonary thromboembolism. Management.